Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my friend and colleague, Dr. Raj Apte, who's a Paul A. Sibis Distinguished Professor of Ophthalmology and Developmental Biology and Vice Chair of Innovation and Translation at Washington University School of Medicine in St. Louis, Missouri. Raj, it's great to have you here. Welcome.
Well, Arshad, it's always a pleasure talking to you, and it's 2 degrees of separation between you and me. We've both been at WashU and UT Southwestern, although at different times. So I look forward to this.
No, it's you are a leader in the space. You know, you dedicated your career to lab research, translational research, and also kind of bringing new treatments for patients. So I'm really excited because you're like the world-renowned authority on targeting lipids to treat age-related macular degeneration. So this episode is dedicated to what you can teach our audience all about lipid biology and targeting and why it's important in the eye. But Raj, before we get there, we always want to know a little bit more about you. So I know you were ahead of me, obviously, at UT Southwestern, and we heard all about this guy, Raj Apte, who was brilliant from everybody. So I want to know, how did you end up doing what you're doing, you know, science, research, as well as seeing patients?
Yeah, so it's been an interesting journey into first ophthalmology and then retina. So I wanted to be a surgeon and a scientist. I was very passionate about immunology, and I did immune privilege with Jerry Niederkorn, got really excited about the eye and how the immunology of the eye is very unique. And then, of course, got interested in retina, which is a very nice, interesting tissue to study science. And you got neurons, you got immune cells, you got blood vessels. It's a part of the brain. And the surgery is cool. So, I mean, to be a surgeon and a scientist, there's not too many fields you can do that, and ophthalmology is one of them. So those are my 2 passions that I felt like I could meld together with a career in ophthalmology and especially in retina. And that's how I ended up there.
Great. And so you say, Jerry, you did PhD with him. Any mentors that kind of paved the way for you?
Yeah, many. I mean, I think we live through our mentors in a way, and you sort of remember them all the time. So Jerry on the science side, Wayne Stryline, who was on my thesis committee, again, a giant in immune privilege. And then through residency, a number of them that, really taught me how to operate. And, even when we do retina, things we do as residents, which we don't do as specialists, but the little techniques you learn, whether it's in pediatric ophthalmology or cataract surgery, we've had just such wonderful mentors at Southwestern and also afterwards in my retina fellowship at Wilmer that, I think you become who you are because you kind of meld together all these things you learn from so many of your mentors. So I'm really thankful and grateful to all of them, both on the science side and on the clinical side.
And well, you have mentored a lot of residents and fellows. How long have you been at WashU now?
So I've been, I'm almost embarrassed to say I'm going to date myself, but I've been at WashU for 22 years now.
Oh, wow. Okay. Well, keep up the good work and you're doing great. So in 22 years, you have really gotten a lot of mentorship done to a lot of people. So that's great. Okay. So you love lab, you love seeing patients, your research group, mentoring and all that. What do you do outside? What's your favorite hobby?
I like to travel, but on a daily basis, I really like to run, just I actually, it's not really running, jogging,
Yeah.
being too ambitious if I say I'm running, but it's a good way to decompress. You can just, think a lot when you're out there. And so I like doing that a lot.
Great. So that's great. You run any marathons?
I used to, no more.
Okay. Great. Okay, Raj. So let's get to the topic at hand. How do lipid deposits such as drusen, subretinal drusenoid deposits contribute to the development and progression of advanced forms of AMD? And, I think all of us are used to drusen as retina specialists, but give us what's going on in the eye and how do we get there?
Yeah, I think that's a great question. AMD, as we all know, it's a disease of aging and it's a complex disease. But there's many factors involved. The key is genetics. We know genetics play a big role. Metabolic dyshomeostasis or abnormalities, and then that driving inflammation, oxidative stress, and other things. And I feel that based on, and this is not just our research over a couple of decades, but many groups, as you know, around the world have worked on it, that lipids and abnormalities in lipids are being recognized now as a root cause of development and progression of disease. So the genetics supports it, at least 4 different, classes of genes. Having polymorphisms associated with AMD risk. The biology, if you look at the metabolomics, proteomics, there's serum lipid dyshomeostasis, and then of course lipid abnormalities in the tissues in the outer retina and the RPE. And then what happens over time is you have problems in being able to handle various forms of lipid in the outer retina and the RPE. We know that there's this large amount of lipid load, right? A couple of tablespoons a day when we shed rods and cones at dawn and dusk that has to be handled by the eye and removed. And with these abnormalities that you develop, both genetic predispositions and with age, other risk factors potentially like oxidative stress, what you get is problems with the RPE being able to process lipids, multiple mechanisms, the technical terms would be like lysosomal function, lipophagy, lipid catabolism, efflux, the ability to clear it out of the eye, take it into the choroid and out of the eye because you don't want it sitting in the extracellular matrix outside the retina and the RPE. Those are not as efficient. And so then what happens is you see this biomarker, which is lipid deposition. And how do you diagnose a patient with AMD? When you see drusenoid deposits, your pseudoreticular drusen or sub-RPE drusen. Or, even in those forms of AMD, like you see in East Asia, where you don't necessarily always see drusen, you see lipid abnormalities. And, it's almost like the lipid's there, you're just not seeing it in focal deposits. So it's at the center of all forms of AMD. It's early in disease. And I think the molecular and biological evidence points now to it being upstream of then what happens over years and decades, right? You then get mitochondrial dysfunction, you get oxidative stress, you get inflammation, and that will drive neurodegeneration and geographic atrophy. But we have enough data now to suggest that that also plays a role in driving, pathogenic angiogenesis and sort of, works against us along with other things like VEGF. So it's a complex cascade, but the lipid dyshomeostasis or abnormalities sit at the top of it, and then it sort of trickles downstream, with time.
Wow, so that's a very good overview because it seems like it's a very complex, biology and pathophysiology as you described. But at the end of the day, when you say lipids, what are you exactly talking about? What does that really mean for our audience?
So again, that's a really good question because there's just so many classes of lipids, right? But in general, you can talk about cholesterol and cholesterol esters. You can talk about phospholipids and other classes, but there's multiple classes of lipids. But I think it would be okay to focus on sort of the cholesterol as a big part of it, although there's other lipoproteins also that are deposited and play a role.
Great. So in terms of like, so you described this interplay between lipid accumulation, inflammation, and oxidative stress. So what do lipoproteins and cholesterol transport mechanisms, play in Brooks membrane changes and RPE dysfunction? So it's just that they're causing inflammation because healthy RPE can clear lipids?
That's correct. So, you think of the RPE as a cell that's, it's like almost like a garbage collector, right? It's taking up all this shed photoreceptor outer segments, and even the myeloid cells, the microglia in the retina and macrophages in the choroid. Their function is to process all this cargo and efficiently send it through the choroid to the bloodstream, essentially to the liver, so that you can make bilirubin. I mean, that's how the reverse cholesterol transport works. And through these risk factors, whether it's genetics and other things, there are problems in these pathways. So then what's happening is you've got intracellular lipid accumulation in the RPE. That's going to make the RPE sick. You're going to have problems, whether it's the efflux transporters that are impaired because of, again, genetic risk or other factors. Smoking plays a big role there. That, again, impair the actual trafficking out of the RPE and the other cells into the choroid. So you can imagine that it doesn't have to happen overnight, right? So it's not an MI that happens like in 5 seconds. But you can now see from the first time you get AMD or see evidence of these drusenoid-like deposits or Brooks membrane thickening, you now have this cascade that happens over years. Because sometimes, right, we follow these patients with early or intermediate AMD for years, and then they start either developing atrophy or choroidal neovascularization or both. And so it's sort of like a slow coal fire, that started, and it may take time, but the patient's on this path to progression. And sort of the next question, that's an obvious question, is why haven't we focused on it? Is because there's, number one, not been great understanding in the past. Number two, there's not been great targets. And third is we've been focused a lot on downstream, right? The advanced diseases for the right reason, because they cause vision loss. But I think our understanding is more sophisticated now, so we can start moving upstream and really get to these initiators, or the true causes of disease.
Well, that would be great, right? I think I agree with you that we have 2 approved treatments for geographic atrophy, but I feel like geographic atrophy is too late to intervene. I think intermediate AMD, and if you have something safe, maybe even mild, dry AMD would be the right targets. I think it's going to become more preventative kind of approach than actually, reactive approach. Once you have atrophy and your RPE and photoreceptors are dead, then you're trying to slow down. So I think it's very, very exciting. I mean, this is, it seems like a very, exciting path for future treatment for dry AMD. So, one question people may ask is like, well, how about just taking statins? Like, why not just take statin? I mean, do they impact, drusins or lipids in the eye, because they work really well for systemic cholesterol?
That's a great question, and I think there have been some, small studies looking at that. They've looked at high dose statins. So it's a good question, because I like to separate what's going on at the RPE outer retina Brooks membrane choroid interface, because remember, in early disease, we're still in a blood-brain barrier, blood-retina barrier compartmentalized situation. So what's happening systemically is a clue to us that, there's problems with dyslipidemias. But I think the real problem is what's going on in the retina, right, and in the RPE. And so an approach that takes some of these systemic agents, with this idea that we'll start removing things. The problem is the kinetics, right? The bioavailability and the kinetics. We might be making changes systemically, but they're not going to necessarily translate into what's going to happen in terms of improving the health of these tissues in the eye. So in a way, what I'm saying is that I'm more in favor of targeted approaches, whether it's intravitreal or something that we can get to the tissue of interest so that we can have, number one, the best bioavailability, the best efficacy, and then, of course, not have to worry about larger dosing and off-target effects that you always worry about systemic agents.
No, I agree with you. I think, obviously the ideal thing would be a systemic approach, but we haven't had anything systemic for any of the diseases in retina yet because, as you said, for obvious reasons, we have, barriers, but in addition, the efficacy and, of course, the safety can be different. So this is a great overview. I want to learn a little bit more about it, and I'm sure our audience is very curious. In terms of, you said that we didn't know much about it in the past. Now we actually know more. We have targets. So can you tell us, summarize in the next 5-10 minutes, what are some of the therapies and mechanisms that could potentially be used to target lipids in AMD? Because I think it's important that this field will move forward. And I think understanding what is going to come in the future now is important for me, of course, as well as all the retina specialists and our audience. So tell us, what approaches are there? Summarize for us, systemic, local, what should we expect, where these programs are and things like that. So that would be really helpful.
Yeah, see, I think that's, it's a huge field now, as you know. And so there are a few things I just mentioned earlier sort of quickly, but, there are many approaches, right? One is you can improve the ability of the RP to intake, right, the cargo, but that's only going to work if you also improve their ability to clear it. So I don't think there's too many therapeutics that would be beneficial if they just improve phagocytosis, right, of this product. Because when I say RPE, just apply the RPE to other cells also, like glial cells and macrophages. But really what we need is a few mechanisms. One is improving lipophagy, improving lysosomal catabolism of lipids, which is how cells handle lipids, and then improving the ability of these cells through transporters that are expressed on the surface to clear this processed lipid with usually the help of apolipoproteins like ApoA1, like ApoM, HDL, some of these particles that are there, they're there in the retina, they're there in the choroid and the blood, and then carry it out. So I think the ideal designer drug, if you want to call it that, is something that you could give at low concentrations in the eye that has good penetration, does not cause inflammation, and that can serve as a carrier to boost these pathways, to help pick up lipid. It's almost like you're giving lipid to remove lipid, right? Because you need these lipoproteins. And so maybe designer lipoproteins, there's many approaches, people have talked about ApoA1, people have talked about other mimetics. And so those are sort of ideas, how to help the eye clear these toxic, extracellular deposits that are causing these downstream problems. The one caveat, and we don't know the answers, as you know well, since you do so many clinical trials, until you don't know until you know. Like you
should run the experiment.
Right. But I think, we have to still think about what makes sense. So one of the challenges in just delivering a peptide, right? Sometimes peptide works, but there's a lot of peptidases and proteases in the vitreous. So I think you need stable structures, where you have apolipoproteins that are packed appropriately so that they're not going to be degraded. But the size is important because they have to penetrate either through the retina, or if you're giving them in a different approach, they have to get to the site, which is the RPE outer retina, so that they can function effectively. And one advantage we have is, as I said, time. These are not things, you do not need to remove everything, right? You just want to help the eye clear the excess cargo effectively over time so that there's no inflammation, there's not complement activation, there's not the drivers of VEGF that all cause advanced disease. And so when you talk about removing excess lipid, you're not talking about curing drusen, right? I mean, that's a whole different concept. It's not removing drusen, it's just helping the eye achieve a more healthy state. In a way, I hate saying it, but I'm going to say it anyway. You're almost reversing the aging process of the eye, right? In people who you've diagnosed now with early or intermediate AMD, with the idea that you're now again shifting that curve of advanced AMD to the right by improving the eye health. And eventually by doing that, you're going to improve these other processes like mitochondrial function. You know very well that mitochondrial dysfunction is being also looked at in many clinical trials. And so, we've been working on this piecemeal, right? Complement inhibition, mitochondrial dysfunction, stabilization of RPE function. But it's almost like the blind man and the elephant, like doing little parts. We see this and we see that. But we need to go upstream so we see the whole picture. And the whole picture, I feel, is understanding that this starts with this idea of dyshomeostasis in lipid metabolism that then is driving some of these downstream processes. It doesn't mean, of course, that for individual patients, they're not going to progress, right? And then it's nice now we have more and more approved therapies in the market, but then also being tested in the pipeline. So the more we have in our armamentarium, right, it's great. But I think most people will agree that if you can prevent the development of GA or you can prevent the development in CNV, that's of course a lot more desirable. And that's kind of what, sort of I'm circling about it in the roundabout way, but that's what statins achieve for cardiovascular disease, right? They reduce the risk of MI and they reduce the risk of strokes. And so I think of GA and CNV as MI and strokes in AMD. And so if you can reduce that risk, you've already made a huge difference in, tens of millions of patients, right? If you can prevent them from going to advanced disease. The one other thing I was going to say is the dosing requirements, right? So here, since you're talking about slowing disease, I think, the treatment frequencies, even if you're talking about a eye approach, intravitreal, let's say, would not be intense. You can imagine you achieve steady state and you could potentially think about a twice a year or once you've achieved that steady state or once a year approach, right? Somewhere in that range. And so that, given the experience we have now, would be tolerable and acceptable in many patients, especially high-risk ones, right, that have advanced disease in one eye, and you're trying to sort of prevent that in the other eye.
No, absolutely. I think if you have once or twice a year dosing, I think patients with early disease, right, with no symptoms will be very amenable to receiving that versus, if it was every month or every other month dosing, then the value proposition goes down. Just like diabetic retinopathy, right? Moderate to severe, we have approved agents, we don't treat them, but we know what the disease will do. It's just a matter of having an intervention that will help control the disease with minimal risk and burden. So Raj, you talk about this is not clearing drusen. So what biomarkers can you see in OCT when you are targeting lipids with many of the different approaches that you mentioned?
Yeah, great point. And I think that's such an evolving field. There's so many people, as you know, in imaging doing such great work. So I think, finding these abnormalities in the outer retina, whether it's, some ellipsoid zone changes, in the OCT, and now with all the AI-led efforts in predicting, abnormalities in the outer retina, whether it's hyperreflective areas or others, that will tell you, who's at higher risk of developing CRORA, if you want to call it that, geographic atrophy in the future. This will help us not just identify the best patients for treatment, but also help us identify the highest risk group. So I think that those are the endpoints we want to achieve: stabilization or prevention of damage, structural damage to the outer retina, that we can measure now, and we'll be able to measure even better in the future. Whether some of the functional tests we have right now, that can be used for this too, remains to be seen, right? And there's a lot of work going on that. And so I think those are the approaches and endpoints that we will use to help us with the types of treatment that we're discussing. Now, these could also be used in advanced disease, right? Where you have GA, which again is undesirable. It's almost like the fire has started, right? But still want to slow it, in our non-foveal patients or small GA patients, and knowing and having this idea that this cascade is still ongoing will help us also treat patients with more advanced disease. I'm going to go out on a limb here with neovascular AMD. I mean, we have made amazing progress, right, with anti-VEGF agents now. But we all know the challenges: treatment burden, sort of under-responsiveness, sort of these plateau effects. And so I think it's hard to beat, anti-VEGF agents on a monotherapy basis, but we don't need to do that, right? We can achieve improvements in these challenges we have with anti-VEGF therapies by combining it with other things that will allow us to maybe treat less or maybe achieve better outcomes, prevent atrophy, prevent fibrosis. And I think some of these things we're discussing, at least the animal work suggests that there's some relevance of that because it's driving inflammation, which, again, is very important in choroidal neovascularization. So that's an area that's somewhat underexplored, but there's some possibilities there.
No, thank you. This is a very thorough explanation and discussion. So one last point. So if you had to design a trial, are you looking at ellipsoid zone changes as a structural outcome? Because, many of these patients, if you're going to target intermediate AMD, may have good vision. And, it's very hard to show a delta in visual acuity because of that, or these are slow growing disease. So are you thinking that these treatment options may go into intermediate AMD, looking at ellipsoid zone, or you're thinking early GA and then showing that we are preventing, easy attenuation or photoreceptor loss?
I think you got it exactly right. I think with any early experimental therapies, right, once we have these targets, you're going to go backwards. It's almost like the Benjamin Button, movie. You start with GA and you test out in your early clinical trials the ability to slow geographic atrophy. At the same time, when you're doing that, you try to get surrogate markers, secondary endpoints to find what's happening in the surrounding retina with the goal of getting more and more ambitious. Then you're finding patients with high risk, large soft drusen, already some changes in the outer retina, and the structural metrics that you talked about. Of course, we would look at drusen volume, Brooks membrane thickening, and other things. And then as hopefully you've identified targets that give you better and better efficacy, you'll want to move more and more upstream in the disease. And the one thing, I talked about local approaches. Of course, there's some systemic approaches, and some of them are in clinical trials now, right? And I'm not saying they won't work. I'm just saying the trials will show us whether it's, some type of supplementing fatty acids or other things. I think, again, we'll just have to be cognizant and mindful of the pharmacokinetics and previous data, like based on AREDS2 studies on, the omega-3 fatty acids, to see whether we are going to find efficacy that is validated in the appropriate clinical trials. So I think the best thing is the focus is on this area now. And so there's a lot of interest, and there's a number of approaches, right? Both intraocular and systemic that are looking at this. So I think it's just good for our patients to have this excitement and interest in the field.
No, I agree. Very well said. I think we have so many shots on goal, right, with systemic and local approaches. And I think at the end of the day, the data speaks for itself, and we'll see what efficacy and safety data we get in the future. But it's very exciting that we are actually moving earlier, hopefully, in the disease and really attacking the core biology of the disease. And I think this is very hopeful for me as a physician, as well as for patients, where we can say, hey, if you have mild or intermediate dry AMD right now, we actually are making progress that we possibly may have something for you in the next 5 to 10 years, where there is very strong science. And thank you to great scientists and physicians like you, Raj, for moving this forward. So I think that was a really good overview. We have a few minutes left for the show, so let's go back to Raj Apte in terms of Retina and your career. So tell me, what is the most important career achievement that you're very proud of that you want to share with our audience today?
So I think, the older I get, I think the more and more I really enjoy mentorship. So because I think what's happening is all of the undergrads, MD, PhD, medical students, graduate students, residents, fellows, they're all having flourishing careers, and it's very rewarding to see that, people you've mentored. I'm sure you feel the same way, and you see them succeed and sort of doing great things. And it's almost like, with each year that gives me more joy than anything I do. And so I think it's really nice to see that. It's almost like your professional children, so that I think gives me the most joy in what we do. And our field is so tightly knit and small that, everyone knows everyone, and it's just wonderful to see that community develop.
No, I think you have mentored so many great people. We actually have one of your ex-resident, David Chinyi, on one of the episodes.
Yeah. Oh, yeah. It's awesome.
So you're going to be, this episode will release, with that episode. So it would be nice to see that somebody you mentored is part of Retina Radar talking about treatment options for geographic atrophy. Yeah, it feels great, right? Like I've had many, fellows that graduated. It's great that they can help so many patients around the country. They can contribute to advancement of the field. So I agree. And obviously, I mean, being an academic physician is not easy. And I think people who do it are really, the core value is to give it back to the field by making an impact for people around the world, right? Because I'm sure you have fellows who are all over the country. Some of them went outside. We all get international fellows and whatnot. So thank you for doing that. Now, one more question is, when you retire, you still have a long career. It's only been 22 years. You at least another 25, 30, if not more, Raj. So what would you like people to remember you for or as? Like, what is the legacy that you're trying to establish for yourself?
I mean, there's always professional legacy, right? You want people to remember that, you really took the effort to understand the specialty or the science that you're doing, and whether it's wrong or right. I mean, you make a hypothesis and you do the experiments. They could be wrong, they could be right, and you want people to feel that, oh, the person left a body of work, right? But I think honestly, beyond that is really these sort of personal interactions. If your students, mentees, colleagues remember you for something else, like, even just the interactions, or enjoyed being around you, I think that's a lot more valuable, than anything else, I feel.
Well, I can tell you, Raj, like you already have created that. You're one of the nicest guys I know. You're one of the smartest, nicest guys I know. I mean, you've done so much work, and everybody has so much respect that when you say something about the science or something that you're excited about, many of us get excited together with you. So, and that doesn't come just directly. That comes from your hard work and your commitment. So I think that's my version of Raj Apte, the nicest, smartest, humble guy who has actually contributes so much to our space. So Raj, what a pleasure to have you on Retina Radar podcast. I really enjoyed our discussion, and I also want to thank the audience for listening in. Thanks, Raj, again for being here. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.